Start it. Okay, can everybody hear me? Okay, in the room here. All right, cool. If I start to move away from the microphone too much, somebody wave me down. Okay. My name is Ben Kraft. I'm going to be the moderator today for Mad Topics ASD and Education discussion. Super happy to be here. Mad Topics is I was brought in by Dr. Simone Kinsey here, which I've been grateful for to be a part of this. And the thing that I really want to emphasize as we get started today is that the goal of Mad Topics is really to bring in both clinical research and lived experience when it comes to the subjects we're discussing, and to hold those things up in sort of equal parts, right? So that will be reflected in today's discussion and in the folks that are here for the discussion today. Again, my name is Ben Kraft. I'm a licensed counselor here in Tennessee. I work at a place called Nashville OCD and Anxiety Treatment Center. We have 2 offices in the Nashville area, and I specialize in anxiety disorders and the treatment of obsessive compulsive disorders. Because of that, I am not going to be an expert on today's topic, but I'm very much interested in it and have worked with folks on the ASD spectrum before in the context of anxiety disorders. And so very excited to be here and learn and to help moderate this discussion as we move forward. To get us started today, that's my introduction. I'm going to have the panelists introduce themselves as well. We'll start with the folks in person, and then we'll move to the folks that are joining us via Zoom today. Okay. So to go first, if that's all right, Dell, do you mind going first?
Greetings. Okay, good. The mic's working. Hello, my name is Dell Zimmerman. So I'm a PhD candidate in chemical engineering. My research concerns developing new pharmaceuticals actually for cancer treatment. And what my lab figured out how to do is we can take traditional chemotherapy drugs, little tiny droplets of them, and wrap them in a plastic film layer. Actually, we can inject these, and the cool part is they'll stick to the cancer, and we can control where they go. So the idea is we can use a very, very small amount, relatively speaking, of these, which in theory at least should minimize a lot of the really horrific effects of chemotherapy. Now, if you're wondering why I'm here, because this isn't like a pharmaceutical conference, I'm an individual on the spectrum. I was diagnosed at age 9. Before I get into, I guess, the explanation of that, which is a wild story, I want to say that we are not clones. We are unique individuals. So if you have 2 children, or you know of somebody who has 2 children, or you have siblings, or take 2 people on the tennis team, for example, you would never assume they're the same person. So please do not assume individuals on the spectrum are as such. We are all unique. That being said, the story behind this is actually quite wild. I was diagnosed kind of in a weird fluke. My family was visiting relatives up north because I had a younger sister born around that time, and we wanted to show her to the extended family. And so an aunt of mine, or my great aunt, saw me, and she told my parents that she knows people like me, and well, they're in prison, which is the last thing you tell a parent. So out of pure spite, my parents brought me to a psychologist to show that everything is in fact running normally under the hood. Well, it turns out I walked out with an autism diagnosis, which was pretty unexpected. At the time, this was quite a long time ago. Such things were really, really uncommon. I think if it was today, it would be a little bit less shocking. So yeah, that was an interesting surprise. But I'm actually really glad we caught it early, because early intervention makes a huge, huge difference, it turns out. I have some numbers on this personally. So this is the results of a social language development test. That's kind of a mouthful, but essentially it measures one's ability to communicate effectively. And I took the first time in 2011. Just for reference, my average grades were really good at the time, 97th, if you average them. Now, in contrast, the language development test results came back as a 9th percentile, which is really bad. If you lined up 100 people, I would be 9 from the bottom, which is just dismal. And it would be a lot lower if you, I had one thing I scored bizarrely highly in, sarcastic language, actually. And that brought up the average at about 4 points, so it should be much lower. That being said, consistent intervention does pay off. I took it again in 2013, 2 years later, scored a 44th percentile score, which is a huge improvement. Average grades didn't change too much. And in 2015, I scored a 64th percentile, which after, at this point, 4 years of consistent work on this subject, plus a lot of other earlier stuff, I managed to squeak out a kind of a mid-D in terms of communication, so hooray. You know, it's still an ongoing process. This was over a decade ago. You know, I mean, it's a consistent improvement. So I like to think that things have improved since then. And I'd like to thank a lot of the speech and language pathologists and counselors. I worked both in and out of school with many of them, and they made a huge difference. So I guess in terms of what this looks like in school, there's a couple of interesting things. So in terms of school, the really memorable thing that came to mind was executive functioning. And this is a group of skills that include things like emotional regulation, organization, breaking down a task into small manageable steps, etc. One of the most important ones of this is working memory. That's how much stuff you can kind of keep in your head at any given point. For computer people, you can think of it as the brain's equivalent of random access memory. I have absolutely dismal executive functioning. This is a pretty common weak area for individuals in the spectrum. And lockers, oh boy. In middle school, I had a stacked locker, so the person below me had to endure a daily avalanche of random school detritus. High school was, at least as a silver lining, did not have stacked lockers. They were a lot bigger. On one hand, that's nice for the person below me, but it's even more space. So as you can imagine, it was just a nightmare. I, at one point, had a teacher. I don't even know who she was. I think she taught Spanish. I took French in high school. And I'm not entirely sure who she was, but she came up to me and just pretty much made me clean the thing out on the spot. It was that much of a problem. The funniest part was, as you'd imagine, with such an organizational system, keeping track of things was a bit of a nightmare. So I'd always do the work. I was a really good student. But keeping track of it to turn it in was kind of a pain. And I found out after I'd wrapped middle school that teachers would actually ask my mom in the car line if I left assignments in her car. And it happened often enough to where, sadly, the answer was it was a yes. It's kind of funny to find that out in hindsight, actually. It seems absurd. The other one that really was memorable was a similar thing. They would actually call home to see if I had a copy of something on the family computer. And I did, but I never gave anything a distinct title. This is not like an executive functioning thing. This is more of like a me thing. And so it would autosave as the first thing, which was usually my name. So we'd have Dell Zimmerman 1, Dell Zimmerman 2, Dell Zimmerman 92, etc. And I mean, kudos to my parents, because I think sifting through that to find the right assignment was quite a lot of work. In terms of other things, kind of from the beginning, I had, right after diagnosis, I had an IEP, and that included a lot of things. So some standard accommodations, extended time on tests. That's like a working memory thing. I had a math teacher who did a really interesting version of this in high school. I had her for a lot of stuff. My school had a really small department, so I probably had her 4 times. And what she would do is she would take out some of the filler questions and ensure that the test had the shortened one had a good representative mix of kind of all the skills being tested, right? So it wasn't easier, but it was shorter. And that ended up working out really well. So, you can be quite creative with these in a lot of cases, depending on kind of, the needs of everything. I also had pragmatic speech weekly. That is essentially how people communicate, working with a speech and language pathologist. And this is a notable one. In middle school, I had a weekly session with my counselor to organize my locker and backpack, and that ended up doing a tremendous amount of good in hindsight. Interestingly, so after graduating, I still have accommodations in college. So in undergrad, I would have things like a transcribe, so it's standardized testing, filling in the little bubbles. If you have difficulties with fine motor skills, this takes an inordinately long amount of time. So transcribe is a way to do that essentially retroactively. Afterwards, you mark the answer in the testing booklet, and then somebody else goes through and just kind of fills those in. And also extended time of testing. Now, the interesting part is, in college, I didn't ask for adaptive technology because, everyone in college has a laptop, at least in my field. So yeah, I mean, they're generally done differently, but you can see there's a lot of overlap. So I think that wraps up my introduction, and I'm happy to answer like any questions if you have any questions about the student experience, for example. Thank you.
Thank you, Dell. That was really informative. We really appreciate it. Do you remember when you said you were 9 years old when you first got that diagnosis? Do you remember what that felt like at the time? You were quite young, but was it scary or more positive?
And I hate to say quite young. Statistically speaking, most individuals in the spectrum are actually diagnosed quite a bit younger, at least as far as boys, that is. As far as how I felt about it, so you have to keep in mind that I was diagnosed with Asperger's syndrome, which is a weird thing that was autism adjacent until the latest revisions of the DSM in 2011 or 2012. So as far as how I felt, well, I was eavesdropping on a psychologist explaining it to my mom, and I thought it sounded like an exotic food. I don't know. I must have been hungry or something. I don't entirely know. But as far as the actual diagnosis, it was kind of weird. It took a while to actually kind of to really understand it. I thought it was. It took a lot to kind of understand what it was. At one point, I thought it was like a disease. I don't know. Truth be told, meeting some cool people who, weirdly enough, had a child on the spectrum, and meeting a couple of a counselor who I really clicked with was the key to really accepting it. It's kind of funny, actually. I was really hard to work with in that regard until boom, overnight. I don't know. I think meeting clinicians that I've meshed really well with was the key. That being said, I would recommend telling your child, if you have a young child who's diagnosed, exactly that. I think that's important to know.
That's great. Thank you so much. Okay, next, Isha, if you don't mind.
Yes, thank you. My name is Isha Chaney. I am a licensed professional counselor in Tennessee as well. I come here with just different roles. I am a parent of a child that is autistic. She's amazing. And also, another hat that I wear is I'm a PhD student here at Tennessee Tech. And right now, a lot of my research is autism and looking at underserved populations and marginalized populations in the rural, especially rural areas, and access to things for people that are on the spectrum and families that are going through that. So really, I come here today just with multiple hats on, just from a personal standpoint, as a parent, navigating your child that is on the spectrum and the different things that come with that, it can be challenging. And I think, from my personal standpoint, I had the positive part of understanding a lot that was going on and understanding how to navigate those things, just because of my field of being a counselor. So I think, a lot, I looked at that and I was like, okay, I get it, but then how many families do not get it? How many families do not have the information to understand what to do next, whether that's in the school system, whether that's, just personally of what do we do as a family, medically, what does that look like? Do you have a physician that supports you, that understands you, that's making a referral for testing, So I think, understanding that just as a parent, that was difficult, even for me, challenging. So then that kind of sparked, then that must be 10 times more challenging for someone else that may not know that. And I think a lot of especially with parenting, there's a lot of practicality there. There's a lot of emotional drainage, I guess, that can come in that, So I think having your support, finding your circle is very, very important. But as far as clinical experience, I've been a counselor for 10 years now, 10 plus maybe. I have a private practice. So, being able to see those families come in and not knowing, and then being able to help provide that or guide that, I think that's something that I get to experience. That's definitely amazing, So, and I think, like Dell said, one of the biggest things, I'm glad you said it, made me smile, made my heart feel good. But having that that counselor that was like, hey, like, you're awesome, this is cool, right? So and giving him that support, I'm sure, and that confidence. So I think just having that and being able to navigate that as a professional, I think that's one of the things that I really strive for. And then giving that to parents as well of, okay, this is doable, right? I think one of the most beautiful things as a parent is being able to truly understand how your child communicates, because that's one of the greatest things ever. There's growth in that, and there's just an amount of time where every party in the family is learning how to navigate that space. So I think some of the things we look at is, yes, it's challenging, but on the other flip side of that, it's a beautiful thing for everyone to grow into. For my research hat, like I said, I really want to look at just underserved populations, and really get the need of decreasing that gap of access, right? So we want to make that access a lot more doable. Getting the diagnosis a little bit more quickly, getting the physicians to understand, and being able to hear the family say, hey, like, okay, can I get this referral? And there not be any hesitation from the physicians. And I think that's one of the things that we need to decrease and get that going. So, but yeah, I guess that's me in a nutshell.
Thank you so much, Isha. Yeah. I'm curious, from my own... oh, yeah, sorry, my bad. From my own work, being a clinician and having some lived experience in my own field, right, I can acknowledge that, like, my lived experience with my own diagnosis and my experience as being a parent often informs how I interact clinically, as it turns out, as opposed to the opposite. How does that show up for you? Just given that you do hold these three roles, how does, especially as being a parent and so forth, how does that tend to inform your research and your clinical work?
Yeah, I think clinically it shows up because I'll get a family in and they're like, oh no, like what's going on, or this, we don't understand this, and part of me, like, I internally I'm smiling because I'm thinking, okay, this is going to be okay, like, and I think just being able to give them that safe space, especially clinically, being able to give a family that safe space to say, okay, you're in good hands, everything is going to be okay. And then guiding them to navigate that space that's unknown. So I think a lot of it is that unknown and then that anxiety that's created around that. So once we decrease that and then being able to provide some of those things that they need as a family or just individually, I think that helps out and navigate that. So, yeah.
It sounds like the emotional insights, the warmth component really comes from that end.
Absolutely.
Yeah.
Absolutely.
Awesome. Thank you so much, Aisha. Okay. Robert, if you're ready, do you mind introducing yourself for us?
As Ben said, my name is Robert Grimes. Unfortunately, unlike Dell, I was not diagnosed early in my life. I was diagnosed at age 20, which was 15 years ago. But it has given me, the late diagnosis has given me a little bit of a unique perspective compared to most of the people who get diagnosed earlier, because back then it was known, but it wasn't as, I guess, prevalent would be kind of the word to use nowadays. I was actually misdiagnosed around the same age as Dell with ADD. And there was, at the time for that DSM, a lot of overlap between ADD, ADHD, autism, and Asperger's. And like Dell, I didn't really understand what was happening or what was going on until I met with a Dr. Robinson, who gave me the actual diagnosis. Although he diagnosed me both with autism and Asperger's because we tested twice. And he was one of the first psychiatrists or psychologists that I clicked with that actually helped me understand kind of my own thought processes or why I do things a certain way. Because the way I did things made sense to me, but did not make sense to anyone else around me, not even my own parents sometimes. But having the late diagnosis has helped me understand the other side of things as well. Not just what it is like living with autism, but also what is it like kind of observing from the outside, because part of what I had to do before I was diagnosed is learn why do people act a certain way when I do something. So I've had to come at everything from 2 points of angles. And unfortunately, I am terrible at speaking about myself, so.
I think you're doing great. So you had to kind of challenge like perspective taking, is what
Yes.
you're saying. And at that age, I mean, I'm curious. Yeah, that must have been hard, right? I mean,
It was, I'd say I've had 20 years of acting normal before I was officially diagnosed.
the term we hear a lot these days is masking.
Yes.
Does that qualify here? Is that
Oh,
what you're
yes.
saying?
I actually had a talk with my mom fairly recently about masking, and it's not just a case of when someone with autism has to do a lot of social interactions, we have to wear a mask. It's also a case of wearing the mask can be mentally draining. I'm sure we've all heard the term social battery. Removing the mask also can drain our social battery, me specifically. I was joking with Dr. Kinsey about, I've been banking a freak out about this panel for 3 or 4 days now. So after this is done and I go home, I'm locking myself in my room and not talking to anyone for about 5 days.
Honestly, same. Would you be willing to give us an example of like what you were talking about in terms of that perspective? Like, what were you noticing that people were reacting to in that space, and what changes did you kind of make there?
One of the most common examples, I think,
Richard, are you there?
one of the most common examples I think of when people
Or
are talking
Daniel?
about interacting with people with autism is we kind of focus.
I'm just wondering if I should be concerned that we haven't started yet, and if maybe something's gone wrong on my end. Daniel, are you there?
Yes, Dr. LeFrançois, I'm here. Can you hear me? Bear with us just a moment, y'all. Can you hear me, Dr. LeFrançois?
I can, yes.
Okay,
Are
great. We have started. We're in the midst of introductions. I'm going to ask you to introduce yourself here in just a few moments, okay?
Oh, okay, so we're not able to hear everyone else. Okay, I understand.
You should be able to now. We just made a change, so it should work now, okay? All right, sorry about that, Robert.
No
Do
worries.
you mind continuing?
We get overly excited about certain topics, and I'm sure we've all seen or talked with people who you talk about one thing and they just completely light up. What I've noticed with most people with Asperger's is we have a tendency to go even further than just lighting up. If you talk to us about our favorite subject, we will talk your ear off for hours at a time. And we won't necessarily understand the social cue of you're getting tired of hearing about that topic, or you want to move on to something else, or you have another question, because we don't really give people a chance to not interrupt, but we don't really take a breath to let people continue a conversation. It's more we're talking to you about the topic you brought up, and we don't have a tendency to let people do a two-way interaction.
Yeah, that makes sense. That's great. Thank you so much for that example, and thanks for introducing yourself. Appreciate it. Okay, Dr. LeFrançois, if you wouldn't mind introducing yourself and just, yeah, telling us as much as you're willing to tell us about yourself and your work.
Okay, thank you. Thank you for the invitation to be here. I'm sorry I missed what the other speakers had to say before now, but I'm very grateful to be here and to be zoomed in as I am. I am a university research professor at Memorial University in Newfoundland, which is in Canada. Newfoundland is an island off the far east coast of Canada. And to help you maybe visualize, Newfoundland is perpendicular to Greenland, but quite a bit south of there. So if you have some, just to help you visualize a little bit where I am. I am a psychologist by training, but I teach social work. And my area of research and scholarship is in MAD studies. So that's a little bit about me professionally, but I also wanted to say that that I'm a trauma survivor, and I refer to myself as MAD. So yes, you did hear that correctly. I use the word MAD, and I refer to myself as MAD. You're not going to hear me use diagnostic labels very often, and I don't do that because I understand madness to simply be something that is in the range of thoughts, behaviors, and feelings that characterize all of us as humans. And I don't think it's particularly helpful for us to turn that range of thoughts and behaviors and feelings into a dichotomy of what is normal or abnormal, or into a dichotomy of what we might consider sane or mentally ill. So I'm just, I'm using words like mad and madness, and some of you might be asking yourself why I'm doing this. And I just want to, underscore, yes, these are derogatory terms. I would say they're a form of hate speech even. However, they are terms that have been reclaimed by people in the MAD movement. And so you might think of this a little bit like the ways in which the term queer has been reclaimed by queer communities. And, what we've done is we've taken a once vile insult, like you are queer, and turned it into a term of pride, right? And so to be mad is to have been psychiatrized, to have been given a label. Usually that label has been given to you by someone who is sane and identified. And you've been given that label, we've been given that label in order to pathologize our difference. And by actually understanding that difference as a deficit, right? So something that needs to be fixed. And so what we do in the MAD community is we take on the term MAD, and we take it on with pride, and with the understanding that we do not believe we are categorically different than any other human beings. Not all of us want to be fixed. And also, madness often brings gifts as well as experiences of distress. It's not all negative. Some aspects of madness are enriching to our lived experience. And what is particularly problematic is that from clinical and professional perspective, madness is always seen as something negative. I'm not trying to glamorize madness and suggesting that, most of the time it is extremely difficult and painful, but at times, sometimes for some people, there are positive aspects that enrich our lives, and that aspect is usually ignored. Okay, so the field of study that I engage in is called MAD Studies, and what we do is we flip the power dynamics and we center the lived experience of MAD people rather than centering the understandings of professionals, of academics, and clinicians. And so in saying this, I have a few questions that I want to throw out to you. I'm not asking for answers to these questions right now, but they're just questions that I want you to sit and ponder for a minute. So first of all, who is in the best position to understand what they are living than those people who are living it, right? Who is in the best position to understand what helpful care work looks like than the very people who have experienced psychiatric oppression, usually through forced treatment within mainstream mental health services? And my third question for you to think about, who is in the best position to understand the sources of our madness than those who have had social, spiritual, and or environmental events or stresses that we can link to our experiences of madness? And trauma plays a part in that for some of us, but not others. So all of this said, again, I just want to reiterate that I'm grateful to be invited to this panel today to focus on autism. You are going to hear me use the diagnostic term autism because it's something that is used by autistic people who understand their experiences as being a part of a continuum of neurodiversity that characterizes all of us as humans. And so what I want to underscore by that is that we shouldn't be thinking about neurodiversity as a dichotomy either, as, okay, so these are the normal neurotypical people and then those neurodiverse people, but understanding neurodiversity is encompassing all of us, okay? I am not autistic, but I do feel like autism studies, and in particular neurodiversity studies, is a cousin field. So MAD studies and neurodiversity studies share a lot of similarities in terms of how we critique the biological reductionism within professional understandings and training. What I mean by biological reductionism is that the professional stance, although sometimes claims to take a psychosocial biological perspective, usually focuses on the biological as understanding the source of problems being within our genes, being within our biochemistry, rather than understanding the source of our issues being in the external world. Okay, and so to go back to we share this idea of critiquing this biological reductionism, and to understand how professional understandings and training usually limits how we understand each other, and those limits actually can produce harmful practices, right? And so there's a critique here that we share within math studies and neurodiversity studies. I think that's all that I'm going to say for now, but I guess I'll invite people from the audience to ask questions when the panel is over if you want to know a little bit more about math studies or any of the issues that I've raised. But I did want to tell you a little bit about math studies to start off with, so that when we're engaging in this discussion in the panel, you have a little bit of a better understanding of where my comments and questions around our discussions are coming from, and they are coming from math studies. So thank you.
That's great. Thank you so much, Dr. LeFrançois. We really appreciate it. Okay, I want to see if we have two more folks joining us via Zoom, but they also have some schedules. So is Dr. Upchurch available? Can you hear me, or are you available to introduce yourself? Maybe not. Okay, maybe not.
I just want to say that I don't see Dr. Upchurch on the screen anymore, so.
That's okay. What about Robert Grimes? Is Robert? No, we already did Robert. I'm so sorry. Richard. Gosh, getting my R's mixed up. Richard, are you available?
I think it's just me on this call.
Oh. Okay. Well, that's okay. We will see if Dr. Upchurch returns. For now, for now, we will just kind of move forward with our discussion. And if Dr. Upchurch is able to join, we'll kind of go back and get him to introduce himself as well. Okay? Okay, so I just wanted to start off the discussion kind of acknowledging that in the realm of ASD, what we often hear discussed is socializing and socialization in general, sort of the social aspect of it. I think in my world, we often hear as clinicians, like, here's the problems that show up with it and so forth. But I guess just to get us going, I'm just curious from the panel, what are some of the difficulties with regards to socialization, but also, like, what might people have wrong about this at the same time? I think Dr. LeFrançois was kind of pointing to some of the things that may be misinterpreted even in this area. So, yeah, just anyone that's willing to that has some thoughts and would be willing to share.
All right. This is potentially a very unpopular opinion, but all things considered, the stereotypes aren't inaccurate here. They're actually pretty accurate. To put it lightly, and from a clinical perspective, autism spectrum disorder is characterized by exactly this. It's a communication deficit. So communication difficulties are, that being said, quite literally the diagnostic criteria in this case. I don't want to be doom and gloom about this, but it is really the thing that makes, autism and not something else. That being said, as I mentioned earlier, consistent work pays off massively. It can make a really huge difference. Also, I would like to ask Dr. LeFrançois, do you really want an answer to your question? Because I feel his viewpoint is horrific, actually, from the neurodiversity perspective. And I mean, I'm happy to answer, but do you really want an answer?
Sure. Yes. But I want to say that I didn't hear what you said just now, where you said something actually helps tremendously. What did you say helps tremendously with communication difficulties?
Well, I mean, a lot of things. The example I used earlier was working on pragmatic speech, for example.
Did you hear that, Dr. LeFrançois? He said working on pragmatic speech. Yeah.
Okay, thank you for that. Yes, I wasn't able to hear what you said earlier because I wasn't connected, so I can't really speak to what you had to say. But please do feel free to answer one of my questions if you'd like to.
Do you guys want to chime in with this question first?
Yeah, and then I'll let you go back to your question that you can ask. As far as socialization, I do think it's a key thing that we can integrate to kind of help, with, and I like to look at it this way. I think there's a double empathy problem, to whereas neurotypical people find it hard to interact with neurodiverse people and vice versa. So that's the double empathy. And I think if we can integrate and it starts early. So if we can integrate things, and it starts in school. So if we can start integrating things in the classroom, in the community, whatever means to decrease that gap, because it is important to socialize. Now, everyone gets the decision on if I want to do that or not, right? But I think when we see that scope of, ooh, I would like to, I just don't know how, then I think that's where we can come in and go, okay, let's fix this. Let's help this. I'm not going to say fix, but let's help this. Because there's I think once those two things start to merge and we start to understand and we start to generate the things that are needed, then that helps with that communication and that socialization. And I think that's very important to be able to integrate that. So. Yeah,
Robert, do you have some thoughts on this question? No, okay, no worries at all. If I bring it back to you, Dell, is it worth trying to answer one of those questions that you were noting?
Fine. Okay. So to start out with, I'm just going to put it out there that the madness thing, that is an extremely fringe thing. I've been involved with the neurodiversity community for 15 years, and I've never heard this viewpoint before. I'm not saying it's not a thing. It is not mainstream. That being said, with regards to 2, it's an almost egregious oversimplification of an extremely complex issue. Well, it might seem intuitive to say that let's ask the individual, and in many cases, you should. I'm not saying the individual should not have a say in the process. A lot of times, what like an individual in the spectrum or a parent will ask for is not necessarily viable. It's what we're looking at here is an extremely complicated issue that's a very complex dance between multiple parties. So to use the example of accommodations in a school setting, you have to comply with the capabilities of the school to provide such a thing, which is realistically doable in most cases, but you'd also have to worry about, is this viable under ADA or IDEA, for example? Secondly, is it actionable? Is it measurable? Third of all, is the requested, whatever actually helpful? Can we show that? I do believe that an individual perspective is important. It's just important to note that there are frameworks we have to work within in the real world, and I think understanding how we can make things accessible or accommodating is a much better approach than burning the house down and trying to redefine everything in terms of the individual's whims. To answer 3, I cannot in good faith advocate for such a thing. To reclaim such a thing like a slur is in theory quite noble, but I can't imagine at least the neurodiversity community as is rallying under such a banner. I understand that autism in particular is highly, highly stigmatized, like highly. I had an interesting experience with an oral surgeon where, I was getting my wisdom teeth out, and you fill out all this paperwork as just tons and pages and pages. They ask you, do you have like XYZ medical thing, like blood disorders? Have you had like any of these things running in the family, etc.? They asked about autism for some reason, so I answered honestly. And I'm chatting, a couple minutes later, I'm chatting with the oral surgeon about the procedure. We're having a normal conversation, and he reads this, and suddenly starts, like as if we hadn't been conversing, and starts speaking in very slow, loud, deliberate speech, using simple words as if I couldn't understand him. I will gladly admit it's highly stigmatized, but I don't think we can. Well, it is very nice to assume we could ignore that. The viability and even the ethics of such a thing, I don't know if that would be recommendable.
Dell, if I could kind of paraphrase, we're not suggesting that the system is perfect, but you are acknowledging that some of the aspects of the functional perspective, seemingly particularly, right? This is how society exists. We need to figure out how to function within it. Is that fair?
In essence, yes. To use a really good metaphor, one of my favorite proverbs is, this is an old Turkish proverb I love, is if a dog's prayers were answered, bones would rain from the sky. I feel like this sums up the serious problems with letting an individual's whims rule how, like accommodations work above all, for example.
Okay, yeah, that makes a lot of sense. Dr. LeFrançois, were you able to hear some of that?
I was, yes. I was just not here for the first part of the panel. I was sitting here, but I wasn't hearing anybody, so I thought we hadn't started yet. So I only heard about 2 minutes before I started speaking my introduction. So yes, so I did hear this, and I thank you so much for your perspective. Here's something that I'd like to say to perhaps challenge that a little bit. What we do know from autistic people is that the ABA and behavioral approaches has, for the most part, been extremely harmful to autistic people because of the ways in which it has forced people to mask and to pretend to be neurotypical, and the harms that that has caused over time. So much so that behavioral approaches are no longer really being used, certainly not across Canada. And this is the result of autistic people and disabled people generally speaking up about the harms that have been caused by that professional approach. And so I don't think that we can dismiss people's lived experience as their whims, or suggest that their whims or their ideas to try to help them live in a world that is not accommodating to them is somehow equivalent to wanting bones dropping from the sky. I have yet to hear anybody who's autistic or mad ask for or think something might be helpful that is so incredibly unrealistic or outside of the world, a range of what might be acceptable or possible. Now, having said that, I did want to speak to the question that you had about socialization. Is it okay if I go back to that?
Yes, please.
Yeah, so for me, this is a really interesting question, and I appreciate the emphasis on socialization. I think that for most people, being able to connect with other human beings is extremely important for all of us, but there are some of us where socializing with others is actually a really distressing experience. And I think of people who, for example, have been traumatized within group settings, and trying to be in groups and interact with other people and socialize can be extremely challenging. And we can also think about people who are autistic who may find it challenging to be in groups of people as well. My question around your question is, maybe we need to pause and step back a bit and ask ourselves, what is our definition of socialization? Are we all assuming that we mean the same thing by those words? And is it a neurotypical or normal understanding of what socialization is that we're trying to impose on other people? I think it's important for us to step back and say, well, what does socialization mean? And when do we know we've achieved it? And I want to give you a little example of this from, I don't know if in Tennessee you had lockdowns during COVID. You might not have, you might have. Certainly in the region where I'm living, we had 2 lockdowns over the space of 3 years where all the schools were closed down and everybody shifted to online. And one of the really interesting things that came out of that is this understanding that not all, but many autistic children in schools started to fare way better academically once they were actually learning online, presumably because they were not forced into the stressful situation on a daily basis of interacting with other people in an environment that might be hostile or stigmatizing for them. And so what we saw and we heard were a number of autistic students actually doing really well and feeling disappointed when the schools opened up again. So what I'd like to kind of get to with this example is, well, what is socializing? What do we mean by it? Does it need to actually mean that we are in person with each other? What about the example of children engaging in parallel play where they're in the same room and they might not actually be interacting with each other, but they are together? From a professional sane identified understanding, we might say there is no socialization taking place. When we talk to the kids who are engaging in that kind of parallel play, what we sometimes learn is a huge sense of comfort in being with the other person, a sense of belonging and friendship with that person, even if they haven't actually interacted with each other. So these are just examples to get back to that issue of do we need to stop and think about how we are defining what we think are in the best interest of autistic people? Are our definitions coming from a place of understanding autism from lived experience, or is it coming from a detached professionalized experience based on randomized controlled trials that seem to be considered the golden standard of research, at the same time as perhaps missing out on how people are living their lives and whether their lives feel livable to them in the real world? Sorry if I went on too long.
No, that's okay. But it does feel like there may be some. Certainly, we're not suggesting that just because socialization is difficult or hard, that doesn't mean that it's necessarily bad for the person, though. Correct? Okay.
I agree with you, but I guess what I'm questioning fundamentally is how we're defining that socialization and from whose perspective and what aspects of it are beneficial. Where is our starting point here?
Sure. I must admit, I may not be prepared to define it that acutely, but certainly the most broad definition, I mean, I think it's agreeable that the parallel play example does count as socialization, absolutely. And even in the example you gave about COVID, yes, certainly test scores and grades may be going up there, but is there not a concern about something being lost as well? It feels like a pretty broad stroke.
Yeah, thank you for that. I am not suggesting that I have all of the right answers of what is working and what isn't. I'm just suggesting that perhaps we need to stop understanding professional ideas as being supreme and start learning from people's lived experience to the point of how we define what we think is good and right. And those definitions, I think we need to deconstruct them, and we need to understand if they're coming from a space of neurotypicality or not.
Okay, thank you so much. That's a helpful thought there.
And I also know there's lots of, I don't know how many people are on the panel because I can't see you, so I'm not sure that this needs to be like just back and forth with me, so. Yeah.
Well, I do think, I do think this has brought up some important ideas that are worth discussing today. I think the idea here in terms of like where clinical perspective shows up and how it shows up is an important aspect. Isha, I'm curious, do you have some thoughts with regards to this part of the discussion?
Yeah, I mean, I think, just hearing when we talk about socialization, going back to that, and like you said, clinically, and trying to put that everything in perspective, number one, when we say lived experience, I think that is the number one key, because socialization looks different with Robert as it does with me, as it does with Dell, right? All right. Ooh, man, I'm good. I'm not good with names either. So I think, yeah, I'm just, because I'm thinking research, and lived experience is one of the things that there's lack of, right? And once we can integrate that and find out what that piece is, I think that helps everything, right? I'm not gonna say it solves everything, but that helps understand. But it is, I think, I'll look at that socialization as developmentally as well. Parallel play, 100%, right? I can play beside you, but I don't want you touching my toys, right? And I'm still like that. So no, I'll go lived experiences all day long with that. Yeah.
I'm curious, in terms of like, as a clinician, sometimes I feel I do have to find some balance between like the clinical work and education and, relating to and figuring out how to best assist clients. Is there a perspective, Aisha, you might be willing to share in terms of, because I can hear the argument here. I think most clinicians will agree our system is imperfect at the very least, right? But yeah, I mean, how do you balance that, or do you have any thoughts to that end?
Yeah, of how, repeat that, how do I balance?
Yeah, just again, sort of this lived experience understanding, and also understanding that our clinical perspective is imperfect, right? As we go and we engage and we do try to help.
Yeah, I think clinically, to answer that, I think the more knowledge that we have as clinicians, I think that helps out tremendously. Because if we have the knowledge to be able to understand and work with this person that we have in front of us that's coming to us to say, hey, okay, these are the things I'm having issues with, or these are the things that, I don't know how to navigate. I think that's clinically having that knowledge and engulfing ourselves into that to where that feels comfortable for us as clinicians to be able to navigate that space with that person that's coming to us. Does that answer that question?
Yeah, I think so. I mean, to some extent, it almost sounds like we have to be like an interpreter almost, right? On one level, right? And acknowledging, because I'll be honest, I'm not dissimilar, right? You won't find me using a ton of clinical language, for example, right? Because it doesn't tend to be very helpful in terms of sort of acknowledging what the person is going through in those moments and being able to connect in that way. Yeah, please, Dell, go ahead.
So I will gladly admit that, socialization, it's hard, it's challenging. And I also will admit that I'm not advocating for erasure of the autistic identity in any way. In fact, no, I think almost no one would. Chris Spinello, he runs a blog called Autistic Not Weird, and did a survey in 2022 with 11,212 respondents. About 2/3 of those are autistic, and the rest are almost exclusively parents or caregivers. The vast, vast majority liked being autistic. Like, that's not something any of us would ever, for the most part, advocate for. I'm going to make this into a bit of an interactive example. So I'm throwing out a question to the audience. Of the audience, who here are math people? Okay. Okay, good. So this will be a good example. Okay, so in high school, you're grinding through that obligatory math class, right? It's hard, it's miserable, there's a test coming up. Like, I'm sure everyone put in a lot of like time and like effort and really, burned the midnight oil at one point to just, get through that awful exam coming up, right? It was not a pleasant experience. It was horrible. And if, that wasn't necessarily math for you, I'm sure there was another subject at one point. That's how socialization works. It's miserable. It's not necessarily a fun process, but in the end, it has massive benefits. We can show those, like, it's a huge, massive deal to be able to effectively communicate. Communication and socialization is the thing that literally makes us human. So being able to do it effectively is massively important. So yeah, no, it's a struggle. I mean, I worked for years and years and years on this, and it's still like a process that's ongoing. Did I hate it? Absolutely. Child me was miserable about this. Like, there's like, I think some of the people that some of the like the clinicians I worked with, like there's a counselor who she had to sit there and endure one of the least receptive like children ever to this for probably a year or so. But you know what? In the end, it worked out amazingly. So yeah, I mean, it will be uncomfortable. It's not a smooth road, but it's absolutely the thing I would recommend.
To add on to that, my learning of social interactions, because again, I was not diagnosed early in life, was very rocky because I was and am a very inquisitive person, so I tend to ask a lot of questions. But in my early school years, I learned not to ask questions because I was apparently asking too many questions. But for socializing, what actually helped me, and some of you will probably find this funny, is acting classes. I actually took theater arts in high school. And that's actually how I learned how to develop my own individual masks for different tasks, is basically putting on a persona to then interact with other people. And I did that, for 4 years, and that helped me a lot. But for people who are getting diagnosed and who are obviously struggling with social interactions, obviously there's not one size fits all. If you've met one person with autism, you've met one person with autism. But going back to what everyone else has said, if you can find a way to talk to the person and figure out what they want to help themselves, instead of trying to do a blanket approach, I think there will be a lot more success in social interactions using that methodology.
Yeah, so speaking directly to the individual about what it is they want, what their goals are, where they want to end up sort of in their life broadly, and then working with them to move in those directions. Yeah, absolutely. Absolutely. I think that makes sense. I am curious, just given the conversation about interacting with the clinical world, given that you were a bit older when you went through that, what is your opinion on kind of that interaction, how that went for you?
A bit of a mixed bag for me personally, because, as was mentioned before, I got diagnosed very late. So I had 20 years of portraying myself as society at the time wanted me to portray myself, not knowing my diagnoses. But now that I have it, it's interesting because I'm having to fight my old habits of how should I act, how should I talk, how should I, present myself compared to what is actually most comfortable for me. I'm fine interacting over Zoom or over Discord or any kind of online interaction because there is that kind of disconnect, and that helps me feel more comfortable. An in-person situation like this, I am very uncomfortable if that wasn't immediately obvious. But I kind of view it as a bit of a training aid by forcing myself to sit through this, not in a negative way. I'm kind of building that endurance so that way the next time I need to do an in-person social interaction, I'm not going to be freaking out as much or struggling as much to get my thoughts and points across.
No, it's well said. Aisha, if I could come to your way again, I think one of the things that he's mentioning here is something we might refer to as distress tolerance. And I'm curious if that shows up for you in your clinical work and working with ASD, if that feels like an important thing to do or not so much. Just curious of your thoughts.
Yes, it definitely shows up. And I think that's one of the things of where that individual has to balance that of, like you said, I get exhausted from this. You'll be exhausted after this today, so I do think that's an important part that clinicians do have to take on and understand of that battle back and forth of what that distress looks like, and being able to, present that with coping skills of what to do with this distress, So absolutely, I think that's one of the things to be knowledgeable about. Once again, listening to the person that is coming to you and saying, this is what this feels like, So, and I think even for you, like you said, this counselor had to just watch this kid just sit over there, but being in that moment, being in that space with you provided that some sort of safetyness to where you could come, like you said, now you're a lot better, with socializing. So, I think it's just one of those things of that clinician has to understand what is presented to them at the time.
No, I think that's great. I think in where a lot of the work may overlap here, in understanding sort of anxiety and other forms of distress, what we often acknowledge is if we can figure out what we value, where we want to go, what our individualized goals are, then the willingness to engage with and have that distress is often higher, right? Sure, maybe some people don't necessarily have goals towards socializations, but those that do, it doesn't mean that distress won't show up. It just means we have to figure out how to allow that distress to be there. Yeah, Dr. LeFrançois, I'm curious if you have any other thoughts based on what you've heard.
Yeah, I think that's a really important distinction that you've made here. And one of my biggest concerns is, particularly with children, is the forced treatment where they're put under this type of stress to constantly mask and try to behave in ways that neurotypical people behave, and how incredibly exhausting that can be. And I do think, and I love the example of, I'm not sure who it was, someone had mentioned going and taking courses in theater to learn how to do these kinds of interactions. That was a choice that was made, and that's fabulous. My concern is what we're doing to some of our children by forcing them when it's someone else's goals and not necessarily their goals. I also think that neurodiverse people have a fairly good understanding around what neurotypicality is, because it is all around us and we are forced to witness it and to try to act in that way. And I think that there is, in the opposite direction, much less understanding from neurotypical or sane-identified people in understanding people who have been diagnosed, because they are the other, they are not considered the norm or normal. And I guess what I'm advocating here is that we spend far more time as professionals and as human beings trying to understand people's lived experience so that they don't have goals imposed on them. And I don't know anybody who will say no to a little bit of stress or hurt or difficulty in doing that math exam if it's their goal to actually pass the math exam. And so I think that these issues are really important. And my concern is how lived experience sometimes, not always, there's some really good clinicians out there, but sometimes how that is considered dangerous or inappropriate to listen to what people feel their needs are at a given point in time, no matter what age they are. And I think someone earlier mentioned about how you can't have a blanket understanding of autism. You meet one autistic person, you have not met all autistic people, and we're talking about such a diversity of lived experience that it seems to me that it is extremely dangerous to take the point of view that as professionals we know best and we don't need to hear from people around their goals, around their desires, around what really hurts them, what is unbearable hurt, what is unbearable pain, what is a life that is unlivable, and what are the things that you can do that are not comfortable for you but will help you reach your ultimate goal. I don't want to go on too long, but I just think there's important distinctions to be made there.
No, I think that's great. I think that's showing some alignment here a bit more than maybe we had seen before. Dell, please, you had some thoughts.
Okay, so this is going to sound really weird, but we actually don't have an inherent understanding just through diffusion or whatever of what neurotypicality actually is. It sounds really weird to say that, and we don't actually. Temple Grandin has a quote that I think put this isn't a direct quote, but it's something very similar to these lines that appears in one of her recentish books. Is she said, "I was in my 50s before I realized that people send secret messages with their eyes." It's we don't, and to imply that we do just implies we're just a bunch of really bad actors, which I'll let the implications of that sink in, but no, we don't. That's what a lot of this stuff is learning how do people actually communicate? Like, how does that work? It's not inherent, and that we're not trying hard enough or whatever. This is not something that we're naturally given or naturally pick up on.
Thank you for correcting me when I made a blanket statement. I will come back and say, however, that I do know some autistic people who are nonverbal, who spend the bulk of their time observing other people and do have a good handle on it. It doesn't mean that they know how to repeat that kind of behavior, but they do. There are some who actually do see it and have an understanding of what it is, even if they cannot mimic it or reproduce it. I appreciate that some people are not as observant as others, and it's important not to give a blanket statement. I also wanted to say that earlier on, and it was probably more like 10 or 15 minutes ago, someone had said that to communicate and to socialize is what makes us human. And I just want to say that folks who are not communicating and who are not socializing are still human.
Different methods of communication are still communication. However, that was a metaphorical statement. I mean, obviously one of the biggest answered questions in the world is, what makes us human? That is simply put my own perspective, but this is in no means suggesting that the typical verbal communication is that per se. I think understanding that communication, we're different communicators in a lot of cases. I think that is important to acknowledge, but I feel like you're painting me in an almost sinister light by insisting on such a thing.
I am so sorry. I can't see any of you, and I have no idea when you're all speaking who each of you are. And so I don't know who you are, and I don't know if you're the person who made that comment. I'm certainly not trying to paint anybody because I don't know who you all are, and I can't see you. And so maybe you're not realizing this, that I have a screen in front of me that is just blank, and I don't know who's talking at any point in time. And your voices, some of the voices sound very similar. I hope that helps clarify.
Thank you, Dr. LeFrançois. And yeah, I mean, I think the overall kind of idea here is like there is a bit of a definition issue when it comes to what is socializing, right? I must admit, it is, we can be very broad in that definition, right? Even folks that we might consider nonverbal, there is communication, there is socialization to some level, I would expect. Is that right, Dr. LeFrançois?
I think so, but again, I think that the experiences are different for each person. So I think we have to be careful. And I'm not an expert on autism either. I'm coming from a Mad Studies perspective, and I'm linking it with some of the neurodiversity studies knowledge that is consistent with Mad Studies. So I don't want to suggest that I'm positioning myself as an expert in this area. I'm not autistic either. That would give me some level of expertise, but it's not the case.
I am curious, the terms neurotypical and neurodivergent are something that often has been used regularly. In fact, I've been accused of both personally. I'm curious if is it reasonable for us to maybe find where that dividing line is, or to attempt to provide. Yeah, please go ahead.
Personally, I'm not a fan of those labels because they're too nebulous to really understand. Neurodivergence could be anything. It could be autism, it could be OCD, it could be anything. And neurotypical, well, who defines what typical is? And who defines, or who says when it's wrong? I say that neurotypicalness is decided by society in general, but society is also wrong in that, because no one's typical, no one's normal. We all have our own quirks, whether or not you are, quote unquote, neurodivergent or neurotypical. That's my take on that. I'm not a huge fan of those two concepts.
Yeah, it sounds like the binary feels too broad, basically. Yeah. Aisha, any thoughts on that? Just
No, I definitely agree. Where neurodivergent, it's not just one thing, like you said. It's dyslexia, it's ADHD. There's it's a group of things. So, the more I sit here and in the middle of these two gentlemen, lived experience, it just keeps popping up because this is what this is, I don't like those terms. I prefer this or this or this. So, I think once we adapt and we learn and we listen, I think that's where the change comes. And the change has to come, and it's only going to come within the lived experience. So I think moments like this, like I'm ecstatic over here. I love it. Like this is the moments that change. It changes perspectives. It changes the walk of whatever part of we're in with the I'm going to say it, sorry. Neurodiversity. So, I think that's the thing that keeps popping up in my mind is this is great of what we're doing right now.
I'm almost curious, we don't have to jump into this, but I am almost curious how we almost developed this binary. I've noticed in some of my own work, there often seems a desire to create sort of an other, often in comparison to our own selves. And yeah, this often feels like one that is hard to pin down for whatever reason. I think there can be folks that have been told that they're neurotypical and probably very much do not feel that way, and vice versa, perhaps. I do not know. Dale, any thoughts on this idea in terms of this binary?
I mean, it exists. Actually, I really don't for the most part. I don't really. Well, I'm an advocate of neurodiversity, but I don't really see how necessarily diving into how this became a thing, this particular, be it a gradient as was proposed by the others, which I personally agree with, or a dichotomy came to exist. I don't know. I mean, it's a thing. I think we should embrace it.
Yeah, okay, fair enough. In terms of where the line is between the two, any thoughts?
No, not in particular.
Okay, cool.
I was
Yeah,
going
please.
to comment on that, if that's okay. It's hard for me to know when to speak if people are pausing or not. When I understand neurodiversity, I understand it as this really wide continuum, and what we see, maybe ADHD on there, we see autism, we also see what's called neurotypicality as part of that diversity. And so I don't understand it as a binary, as a dichotomy, but again, this continuum of what it means to be human without suggesting that one is better than the other. It's just difference. It's just our different ways of processing and being in the world. And I feel like if we could come to that kind of understanding, there would be less stigma, there would be less violence, there would be more accessibility and accommodating of those differences without forcing people to try to act like that little rung in the continuum that's called neurotypical.
How do we define neurotypical? Dr. LeFrançois, is that?
Well, I guess that's, it's sadly the central part of where professional, and I'm going to say it comes back to white male rationality, and we can even go back to the beginnings of the university and the foundations of whiteness being a part of this, and maleness, and having a very narrow idea of what is considered knowledge, what is considered, who is considered a knower and who is not. And so I think when we try to think about why it is that we see some things positioned as superior to others, we have to go back into that history of othering that takes place within white Western culture. And so, what we have with this idea of neurotypical is this idea of a certain way of thinking that is right and everything else being other or wrong. I don't want to define it because I think it's hugely problematic in its existence.
Actually, she raises a really interesting point when it comes to the gender aspect of it. In general, we've known this for a while. We are really, really bad at diagnosing women on the spectrum. Like, really, really bad at it. They exist, and a lot of efforts have been made in recent years to improve that, but it's actually astounding. So a recent study conducted in Sweden actually found that after the age of 20, the rates of autism, at least in a fairly large population in Sweden, were about 1.2 to 1 with regards to the male-female split. Now, usually, at least in children, it's 4 to 1, and in adults in the U.S., it's 3 to 1. So the methodology for this particular study looks actually very apt, and it has some very interesting implications that we are even worse at this than we thought. So, how this came to be is actually pretty easy to explain. The definitions of autism were written, as almost all medical definitions were, and psychological definitions, mostly with men as the example. So what you're seeing is, like disruptive boys, for example, and like the school environment is where we get a lot of this from. So yeah, it's quite disturbing, and it's actually I think something that will, what we're improving at. We have a massive long ways to go.
No, add to that, like, there's, to the research part of that, there's such a deficit as well, just with marginalized populations in research. A huge deficit. So I think we got to look at that and look at, okay, how do we change that, right? So hopefully my research will come in handy. But yeah, I mean, the deficit's it's unreal. It's unreal. But I think there will be some changes, but we have so much longer to go to change and to adapt to that.
Sorry, I forgot one key statistic. It slipped my mind. Sorry. One of the things that I found, I was doing some research on this, is women actually receive 7 diagnoses on average before receiving an autism diagnosis. It's just disturbing.
I will add to that, just in terms of my own work as a clinician. To be a clinician in this age, a mental health clinician in specific, is to acknowledge that we are a part of a history that did mostly center around a white supremacist model and did center around an idea of normal and abnormal, right, in ways that were usually central to this theme that I think Dr. LeFrançois is noting here, but also what Isha has noted as well. And that is certainly something that I think most, I can't give numbers, but I think most of us are both aware of and hoping to challenge in our own work. And if that awareness is not there, then it's certainly something that needs to be, I would suggest. Yeah. Isha, any thoughts on that? I know.
No, I agree with you 100%. I think it's, like I said, it's well documented that there has to be improvements, and, it's well documented that there's definitely a deficit and lack of. So, yeah.
Well, I'll move us forward a little bit. We've already kind of touched on this, but relationships is another theme out there in the discussion of ASD. We see it everywhere. There's TV shows about it even now, right? And it seems to be part of the discussion in a very broad way. I think for this discussion, we've already kind of acknowledged and defined the idea that, hey, some folks' socialization will be important, and for some it will not. And so perhaps this is an idea that will stick to the former group a bit more. But I'm curious for those with lived experience, right? What is that experience with relationships? What might be valuable for folks to know about that? And are there any myths associated? Is there any bad info out there that you guys have come across?
I've only had a couple of relationships with girlfriends before. I think the longest one lasted about a year. Most others were a lot shorter than that. But with that, I actually don't know what could or couldn't be classified as a myth regarding autism and relationships, or any advice to give, simply because, sometimes relationships work out, sometimes they don't, and sometimes it's because of me or sometimes it's because of them. I think that's a lot more, it's difficult to point to specifically saying, why is this a struggle with people with autism? Because it's a struggle that everyone has, not just autistic people.
Yes. No, I certainly agree with that from my own perspective. Dell, I'm curious if you have thoughts on this idea.
Okay. There is a pervasive myth that individuals on the spectrum don't find partners, which is patently false. I know a ton of people on the spectrum who have had, they're married, they have kids, they're in a happy relationship, etc. Like me, for example, I've had comically bad luck with dating. One of the people who, one of the people who I had been dating for a while, well, that happened right for COVID, and then she went to grad school in Illinois. So, I was back in Tennessee doing my undergrad, so that kind of killed that. And then history is a weird way of repeating itself. I don't know if I'm cursed or something, but one of the people I was dating later, when I was working on my master's, she unexpectedly had her lab, her PI, had some weird stuff, and she ended up moving to California abruptly. And long-term relationships, they're difficult. But so no, there's lots of people in the spectrum in happy relationships. Also, it's actually not true that neurotypicals always marry neurodivergent. There's plenty of people who marry other neurotypical people. There's plenty that marry neurodivergent. It goes both ways. Overall, I just want to emphasize that I think we can be great partners, parents, and role models.
Yeah, thank you for that. That's great. Aisha, any thoughts just from, because again, you have this perspective kind of going all the way around. So just in terms of relationships in this area, any thoughts?
Yeah, I go back to, it doesn't matter who we are, as long as when we find our person, I think that's it. And it doesn't matter. It doesn't matter. It's just we find our person, and then that's our person. So I think it evolves with that. Whether we're on the spectrum or we're not, or we're this race or we're this race, it find your person, and your person will come to you.
Dr. LeFrançois, if you have some thoughts, just broadly.
I want to say that I like that you just said that, but I suppose I want to address this more from a perspective of social isolation and thinking not just about autism, but mad people generally. We know that there's increased rates of social isolation. And so that makes it harder for people to find their person, to form relationships. And I think that social isolation is, for the most part, not entirely, but for the most part, a result of people being scared of mad people, people thinking they're dangerous. I guess what I'm alluding to here is stigma and what we call in mad studies sanism, which is the oppression against people who have been diagnosed with one of these types of disorders. And I think that as a result, although I'm going to say some people find diagnosis helpful, I think generally diagnosis carries a heightened risk of sanism, of stigma, and of social isolation. So there's myths around dangerousness, there's myths around understanding mad people in ways that are not accurate, that I think that we need to create a cultural shift in how we understand people who are different, so that we do not associate difference with dangerousness, so that people have people who have been deemed mad or autistic or any of these other diagnoses have more of an opportunity to not be socialized, not to be socially isolated, and to actually meet people to form those relationships. So I just, that's just like a broad stroke thought that I had around those connections with culturally how we tend to put into one group this idea of these people who we shouldn't interact with because they might harm us in some way. How do we spend time thinking about how we educate our children and educate ourselves to not be frightened of otherness?
Thank you for that. That is curious, and I'll talk to the whole panel now, right? I mean, I think that perspective of stigma as blocking to interaction and relationships is certainly something that we want to work on. I'm also curious, though, of the other side of it. Social anxiety, distress around socialization often exists as a symptom within these things that we're talking about today. And so, I don't know, I'm seeing sort of a continuum here as well to some extent. Certainly stigma is a piece of that, but also what about the inherent sort of psychological distress that may come up in trying to engage in relationships? Any thoughts? Yeah, please.
So, I'm looking at the paper of the questions, and question 2 is just too easy of a segue into socialization and relationships in the education setting. From my perspective, part of the issue with the social anxiety, social stress is just inherent to how the education system is as a whole, not in terms of what we're teaching, but in terms of what happens like in the hallways or when the teacher's not in the room. I was bullied for many, many years by students and occasionally, unfortunately, teachers. And that was part of what trained me to not interact with a lot of people because I didn't want that to happen again. It was, I think the term is negative reinforcement. Yeah. But if non-educational social interaction can be done obviously in a positive light, that will help a lot of us with better understanding the process of social interaction, getting friendships, getting into potential relationships, and it would help us not necessarily want to, but not need to socially isolate, so we don't get that anxiety or that stress.
Yeah, it's not one or the other in this case. It's a bit of a cycle, is what you're acknowledging. Yeah, and so some of these experiences, which are reflective somewhat in what Dr. LeFrançois is mentioning here, the stigma that shows up and the difference in treatment will then effectively change how people are able to interact with and feel about relationships in the future. Yeah, awesome. No, that's great. Thank you. That matches, by the way, in terms of anxiety, right, in general, whether it's about something specific or more general or something that is, has a focal point on a fear. We do see it work through a cycle, right? There's generally a trigger and then some type of reinforcement and so on. So I think that makes good sense. Thank you. That was helpful. Any other thoughts on this idea?
I think
That's
you had...
a good. Nope, sorry. Go ahead, please.
No, go ahead.
It's hard to jump in because I can't see you all. I'm missing all those social cues. I think as a helpful clarification around what you mean by, stigma's part of it, but there's also these inherent symptoms that are in relation to socialization. And I guess that leads me to the question of, is the unwillingness or inability to socialize, is that part of our biochemistry and our genes, or is it part of our lived experience of socialization at a young age going very badly, and you learn not to do it because, and I think that was a little bit of an example around bullying that we heard from the previous speaker. And so I guess I would caution around what we understand as an inherent symptom outside of our experience of interacting with other people. I don't know that there's ever been a gene that's been found that suggests social anxiety is coming from our genes or from some kind of biochemical reaction outside of the experience of some kind of social trauma, whether that's a major trauma or a minor one. Just throwing that out there as an idea.
Social anxiety does exist without trauma. That is just in terms of the clinical sort of current representation, right? We are able to see those two things as separate. But you're feeling like there's likely going to be some type of trauma or some type of experience that has led to that social anxiety?
Maybe not trauma, but something in the real world rather than something inside your biochemistry or your genes that are leading to that. So we might understand from the DSM that social anxiety is a symptom that doesn't come from trauma, but we also, the DSM and no research actually points to any genes or chemical imbalance that actually has caused the social anxiety. So I think that we need to continue to ask ourselves the question, what is happening to us in the real world to lead to that anxiety around socializing with others?
Yes, thank you. That is understood. Aisha, I think you had some thoughts before.
It's gone.
That's okay.
I'm so sorry.
Oh no, don't apologize. No worries at all. We're just having a discussion, and that will happen sometimes. No problem. Oh yeah, go ahead.
Honestly, I mean, social anxiety is weird. Okay, most people, like individuals on the spectrum have it. Everyone has it at some point. I mean, like everyone who's listening, think back to your first date and just how weird that was. But as far as actually determining the genetics of all of these things is a massively complicated, completely non-understood issue with all sorts of weird environmental factors indicated in the process. Researchers are very much looking at this, and it is still very much beyond our comprehension and capabilities to understand. That being said, weirdly enough, I don't necessarily know if digging up a root cause, there is not a sole biochemical cause, we can safely say at this point, but I don't know if that would be the best approach. This gets into some very murky territory about curing autism, which is very, very controversial, and I feel like most individuals in the spectrum, at least judging from the statistic I shared earlier, over the vast majority of them being proud to be autistic, would necessarily recommend such a direction.
Yeah, agreed. I think that makes sense. I think most of us have the understanding that we're not going to be able to limit these things to just genetics. Yeah. Here, to be more broad about this discussion, here, see, I've written, what would you want a neurodivergent person to know about the neurotypical person they're in a relationship or vice versa? Just in curiosity to like what the experience is like subjectively to go through, right? And if there's just anything there that would be helpful or informative either direction.
Well, with the two serious girlfriends I had, they were aware that I was autistic because I informed them, because I was diagnosed before I started dating them. It wasn't all that bad. I mean, they had their quirks. I had mine. Most of the time, like parallel play. For example, I remember I had a girlfriend over at my house one time. She was playing my roommate's Wii, and I was just reading a book on my phone. We hadn't talked to each other in, I think, a couple of hours. We were just sitting next to each other on a couch. She was playing a game. I was reading a book. And that was our social interaction. And we were both comfortable with that. But from an outside perspective, I can see how that might be a little weird to count it as a social interaction because there's not a lot of socializing. It's just two people existing in the same space. But something to understand is for someone like me, or even potentially Dell, if you don't mind, that is our social interaction. We are comfortable doing that because we are with a favorite person. Doesn't matter what we're doing, but we are enjoying the time together in our own ways.
Yeah, thank you for that. I think that makes good sense. I should just, again, given just that you've kind of been all around on this, is there like particular thoughts or advice with regards to relationships?
I think it boils down to that, that understanding, and understanding that person that you're with, and that how are we going to communicate that, right? How are we going to communicate our likes, our desires, being able to come to a point where, okay, it's okay that I'm on my Kindle or whatever reading and you're playing Wii and we haven't talked. Like, that's okay. So I think just coming to that understanding and knowing that, that's still love. I think just understanding what that is. And like you said, I'm okay because I'm with my favorite person. So I think that's what it, boils down to is we can communicate that, and we communicate that early, and then that understanding is there.
So clear, direct communication, yeah, on both sides, seemingly, regardless. Yeah. No, that's great. That's great. I want to move to talking a bit about education while we still have time. All the ideas we've talked about already, socialization and relationships specifically, right? They are going to have an effect in the education system. We might acknowledge, for example, that most of the education system, well, from my perspective, is about interacting and having some relationships inherent in it. So that being the case, I want to be very broad here. What are some of the concerns you guys might notice or have about the education system and how it interacts with ASD?
Well, I think so. To get back to the survey I mentioned earlier, check this out, by the way. It has really good charts for just tons and tons of different things. One of the most interesting ones was actually with regards to school. So the question asked was, my experience at school is positive. And of the autistic respondees, over 70% disagreed or strongly disagreed that their school experience was positive. Of the remaining ones, 15% was neutral. And an astoundingly small 1.64% strongly agreed that school was a positive experience. That's about 1 in 60 autistic people. Honestly, one of the more interesting things to quote this was, quote, one would imagine that the Asperger's genius stereotype would make school easy for a lot of autistic people, quote. It's kind of ironic, actually, when you think about that stereotype. But no, I think that just the general experience in schools for respondents to this poll is rather illuminating.
Yeah, thank you. Yeah, Isha, go ahead.
Yeah, and I think one of the things looking at schools is being able to incorporate a classroom, a school that is inclusive of an autistic child. And I think that's one of the biggest things. And I do think it starts with, I know we have one school counselor, yeah. And I think it starts there. I think the school counselors can bridge that gap, as in, informing the classroom, informing teachers. It's knowledge. It's doing those things prior to the school year. So being able to incorporate that inclusion in the classroom and helping other students understand what this may look like in another child, and how does that other student communicate without exclusion. And I think that's the biggest thing.
I agree 110%. Kudos to school counselors. You're the MVPs.
I'm curious if just for any teachers that are here today, right, and acknowledging that teachers in their own right aren't always going to be neurotypical, but nonetheless, in terms of making it a more inclusive space, in terms of making sure that we are showing up for these students, any thoughts or advice there?
Yeah, absolutely. I think there's so many things that we can do and teachers can do without having an IEP or without having a 504, right? So I think even in the classrooms of just being aware of when a student needs a break. Being aware when a student is overstimulated by light, smells, all the things, a test coming up. I know for my child, I have to feed her a big breakfast because we are not eating at school. We're not eating at school. She will say, it smells horrible. The other kids are disgusting, and I smell ketchup. And if she's not doing it, so I pack a lunch every day. Same thing, and it comes home uneaten. But right after school, we're going somewhere to have, I guess, really her lunch. But no, I think it's being aware of those things, because I'm sure if a teacher, and I know teachers are so busy, but I'm sure if a teacher pulled her out every once in a while, say, hey, all right, come eat lunch with me today. I guarantee the kid would eat, But it's just making those, being aware of, okay, this student needs me right now, right? And I think just being able to, like I said, inform other students of we're making our classroom a safe space for everyone.
Adding on to that, with the lunchroom example, it could also just be this case of there's how many students in the lunchroom and it echoes. I've got sound sensitivity as part of my autism, to the point where I almost always walk around with noise canceling earbuds because I need a quieter space or I need to minimize what's going on. I hated the lunchrooms. They were too busy for me. But even, as an adult, whenever I go traveling, I was at a hotel with my parents over winter break, and across the street from the hotel was a bar and barbecue. The food there was amazing, but from inside the hotel room on the 5th floor, I looked outside and could feel the window shaking from the music going on. And I told my dad, yeah, I'm not going out to get dinner. You can go get it. And I didn't leave the room because I knew the instant I stepped outside towards that noise, it would not be a good night for me.
So one of the things I like to tell teachers that I think generalizes what these two have said is that when a child on the spectrum exhibits a change in behavior, always consider a possible sensory issue first. Seriously, sensory can cause a lot of issues. The source might not necessarily be obvious. There's a quote I really like from the blog of an anonymous autistic, and it's I cannot tolerate the sound of noodles being stirred. That horrid squishy sound. And I'm a PhD student. We get paid peanuts, so I've made a lot of instant noodles, and I've used this quote for years, and so you listen every time, and I still don't think I've ever picked up on that sound. So I don't know. I think this is just pretty indicative in general, and the best thing you can do is ask the student's parents. They will provide you with good information on this. I think one of the other interesting things when it comes to classroom management in general is that honestly, a lot of the things you do for your kids on the spectrum, they're beneficial for the whole classroom. It sounds a little bit ridiculous, but you can do a lot of good for everyone, just with a couple of small changes in a lot of cases.
Following with the sensory issue, the other thing that is very obvious for me is I have light sensitivity. It's where I wear these glasses or occasionally put on my hat. With a lot of the classrooms that I've had, going in college or even high school, white paper, black text, it aggravates a reading condition I have. Couple that with the flickering frequency of standard fluorescent lights or the constant buzzing sound. I see I see one person that heavily agrees with me. So like LED lights, for example, because they're constant, it's not a pulse or even a warmer color. Instead of harsh lights, maybe something more warmer. Just even simple things like that, as Dell said, not just beneficial for us on the autism spectrum, they're beneficial for everyone else in the classroom.
Those are great tips. Thanks, guys. Dr. LeFrançois, just given that we may have to accept the education system as it currently is to some degree, but also certainly understanding that a rebuild would be beneficial. But in its current capacity, what is your thought on how we can make that a better, more welcoming environment?
I see that you anticipated my response about this being a macro level change that's required rather than it being on the backs of teachers, because of the way you phrased that. I want to start off by saying a couple things. I'm in a different country, different educational system here, so I'm not entirely sure how relevant my comments will be to you folks. I'm also, although I've had kids in the education system in my region, I am not specifically doing work in the K-12 area. But what I can say is, from a pedagogical perspective as a university professor, there's been a number of us, particularly those of us who are in the fields of critical disability studies, where we are working to make, to not just provide accommodations to particular students who have been labeled as autistic or having other disabilities, but engaging in more of a universal design so that we're creating spaces that are accessible rather than ones that require accommodation. So this gets to something that I'm not sure someone said a few minutes ago about, creating these kinds of changes are usually beneficial for everybody and not just those students who are disabled and in need of accommodations in some way. And so it does mean thinking through how we make all of our spaces that are sensory, where the lights are not overly bright, where there isn't a kind of noise that can be distracting or harmful to any particular student. It's about thinking about how we expect work, that the academic work that students are doing, to understand that could be demonstrated, their learning could be demonstrated in different ways depending on students' strengths, so that we're creating spaces where autistic students or other disabled students do not actually have to ask or tell you that something in the environment isn't working for them. If we create spaces where, and yeah, this doesn't get to what you're trying to ask me to say what can be done in the system that we have now. I do believe that trying to do this on the backs of individual teachers is really difficult without the support from the broader heads of schools, the school boards, where money and resources are put into creating spaces that are safe and comfortable for all students. And if eating is an issue, then not all students should be forced to go into a large, noisy cafeteria where there are lots of people and lots of smells. So it does, I'm sorry to say that I can only answer your question by saying that we need to go back to the drawing board and think about what our buildings look like and how we create these kinds of spaces that are accessible to everybody. Sorry if that disappoints.
No, that's okay. I certainly understand and appreciate the outlook there. In noticing my time, I do want us to make sure we have some time for questions, but I also feel it is worth bringing up a final point just briefly. One of the things that we've noticed in clinical mental health settings is that the tendency to self-diagnose has increased greatly recently. In the past 4 to 5 years especially, those numbers seem much higher, and there seems to be some relation to sort of social media in connection to that. Just curious if the panel has thoughts on this idea, and Isha, for you, perhaps, like, what has been your experience with that?
Yes, I do agree. I think I was gonna say it's trendy, but once I hear it and it comes in my office, and I immediately hear that, I really like to differentiate, like, okay, social deficit, and we got to have a repetitive behavior, and that's the two things that I really emphasize. And then I'll often get, well, okay, maybe not, right? So I really, when I see that, when I hear that, I really try to emphasize, like, okay, let's look at the things that truly will say, yes, this is a diagnosis. Of course, there's always going to be that historical information that I'm looking at as well. But when I hear the trendy part, and I kind of already know that it's coming through, I'm like, all right, wait a minute. So, but yes, I do think there has been an increase of that, and the popularity of saying that, But I think too, as far as increase in as far as diagnosis, I think that's become because of the knowledge is there, and I think physicians are understanding that and possibly listening to parents more, adults more. Adults are finally getting a diagnosis to say, hey, okay, now I have this understanding of what's going on. So, I think there has been an increase in diagnoses. But then that trend part, I do think the social media has influenced that. But once, it's going to take us as clinicians to go, all right, let's pump the brakes there and look at these two things that we know for sure there has to be a deficit in. So
it does sound like you're noting there is a silver lining to it, though, at the same time, in terms of knowledge and so forth. Yeah, Dell, any thoughts on that?
Honestly, I see it as just kind of it's kind of harmless. I think it does a lot of good for raising attention in general, but I mean, a self-diagnosis isn't really going to do you much in the real world. So I just kind of see it as a trend that's like a thing, kind of like flannel coming back into fashion, for example.
That's great. Robert, any thoughts? Yeah.
I'm going to jokingly say WebMD is to blame for self-diagnoses. But so there are benefits to the knowledge of this is what something can look like. I'm emphasizing can because, again, every diagnosis is different. But there's also a fair chance of harm, because if someone self-diagnoses themselves, they might mistakenly start trying to self-medicate or self-regulate. And sometimes that can work, but most times it doesn't. So my issue with people who are self-diagnosing is, unless you actually have the knowledge and the degree and the experience to do that, talk to someone who actually does have the knowledge, the degree, and the experience, whose job it is. Because, yes, it could just give you the confirmation that you know, or it could be something else, something related, but with how often we're wanting to take depression pills or anxiety pills. I take anxiety pills every night. You could mistakenly take something that will actually cause more harm. So I would suggest strongly to try not to self-diagnose.
Dr. LeFrançois, any thoughts on this with regards to social media and self-diagnosis?
Yeah, I'm going to be brief, and I'm going to say that sometimes having a diagnosis is really helpful to people, and if they're reading things online and it resonates and it makes sense and it is helpful in some ways to them, then that's probably the reason why it's happening. But at the same time, I would suggest that most people who are self-diagnosing are then going to their doctors to obtain an actual diagnosis. Certainly that happens in Canada, where we have free healthcare anyway. And the risks with that is that you increase the risk of being caught up within the mental health system and being harmed by it.
Yeah, makes sense. Thank you. Okay, now, if it's okay that we extend our time just slightly, I do want to open up questions from the audience. If anybody has any that they would like to ask anybody here. Yeah, please, go ahead.
course, Jules. So as I mentioned during my introduction, I was misdiagnosed with the ADD and lived with that diagnosis until I was 20-ish. Getting the actual confirmation diagnosis of Asperger's or autism was immensely helpful for me, because then I could look back on my life and be like, okay, that interaction now makes sense. That interaction now makes sense. This reaction makes sense. And it was almost like, I don't want to say it was a checkbox, but everything just suddenly clicked, and it's like, okay, so now that I know the reason, what can I do to help myself be better about how I respond to things, or how can I better interact with people, knowing what might cause issues for me. Getting the confirmation was probably one of the best things that's happened to me.
Sorry, real fast. I just want to make sure to repeat the question, because folks that are here via telehealth, or excuse me, via Zoom might not have heard it. So the question was essentially, one of the audience members has a close friend who has been considering the possibility that they may fit into an ASD diagnosis, but has been really questioning the utility of going and getting that diagnosis professionally. Is it beneficial? Is it worthwhile? Yeah.
I mean, actually, I know a lot of people who are diagnosed in college. I attended college with a lot of weirdly large amounts of people who were diagnosed as adults, actually. And the explaining everything viewpoint is quite common. This checks out, too, with other things. The Spinello survey, they found that 9 out of 10 autistics actually knew they were different from an early age, that makes a lot of sense. I mean, it's not terribly politically expedient at the moment to carry an autism diagnosis, but honestly, in a lot of real-life applications, it doesn't really pop up. Like, you'd have to disclose it. So downsides-wise, there's the cost of actually getting it, which can take a little while. But ultimately, that's about it. Ultimately, I think it's their decision, but I think if they do believe that, it would be worth exploring.
You know, I think coming from a clinician and one that, you know, I've had the ADOS training, and that's the test that I use. But, you know, I think looking at, and I always ask, especially if they're coming in as an adult and trying to figure that out, the benefits, like how is it going to be beneficial for you? What does it change for you? And I think that's one of the biggest things, like what will it change? And a lot of it's understanding, like Robert was saying, it's the understanding that, okay, now things make sense, right? And depending on the age, you know, I think looking at career-wise and being able to advocate for yourself later on in your career, I think that's huge. And that's where we're going to see a lot of changes as well, just, you know, in facilities, and not facilities, sorry, but in career-wise, like, what does that look like when I walk into my job every day? Like, go ahead. Yes. Mm-hmm. Mm-hmm. No, I think it goes back to understanding. Like, if that's what that person needs, that 40-year-old needs to understand, okay, now it all makes sense. Sometimes that's a relief. Sometimes it's like, okay, I can let everything off my shoulders now, and it all makes sense. Because what that person may be doing is putting themselves in a box to say, I'm different. When really, you're not different at all. There's things that are out there that's like, okay, I see that from a different perspective. I see that from a different perspective. So that could be relief of, all right, like let your butterflies go, right? Like open that box and fly. So, yep.
Dr. LeFrançois, the audience member was asking about somebody they know in their 40s and the possibility of maybe trying to get a diagnosis. Given your perspective, is that something you would be concerned about? Would you, yeah.
No, I would say that I think that there are less downsides to getting an autism diagnosis than as an adult. With children, it's a little bit risky because of the possibility of being forced into behaviorist approaches to treatment that can be harmful, and that we've heard from autistic people as adults that it was harmful as children. But I see less problems with less negative sides to getting a diagnosis around autism when you're in a position to voluntarily accept treatment or not, rather than it being imposed on you. And one of the big benefits of being diagnosed, I think, is then you gain membership into the autism community. And, you know, there's a huge autism community online and also in person in local communities. And so it allows you to meet your people in that regard as well.
That's great. Thank you. Okay. Any other questions from the audience today? Yes, ma'am, please. Let me just repeat the question for those that aren't here. So, and you'll have to correct me. Is that okay? Okay. So specifically, we're noting, hey, we've already discussed how ABA and some of that behavioral work might have caused harm to this community. And so the question now is, okay, so what do we think of the more individualized plans and the more individualized approaches? Are there ways to even enmesh those two? Or rather, how do we now build something to move forward that doesn't cause that harm?
You know, I'll say, ABA world. You're right. There's some things that had to be corrected. There have to be corrected, right? And I think the moving forward with individualized plans is definitely key. I think moderation to everything is key. Okay, how am I gonna word this? I've had to do my work on ABA, so I'll say this. I'll keep it simple. As long as it continues to be individualized and moderated, and the things are moving forward, and the parents are part of that, and I think that's where it really has to come in play as well. And then I think there can definitely be some benefits and some movement there. Yeah, I'll say that. I don't know if that answered your question. As an alternative to ABA's. Yo, you're asking a licensed counselor this. Of course I'm going to say more individualized things. No, here's the thing, and I'll just be honest. It depends on the person. It depends on the situation, right? Because there's times where individualized counseling is not going to do it, right? So I think it's and that's where I say it takes a team. It really does. And that team is physicians, that team is occupational therapists, that team is licensed professional counselors, school counselors, yeah, PT, OT, all of it. So I will say this, in a perfect, beautiful world, if all of those folks would talk and communicate, oh wow, like that would be great. But that's not that. So I would say, hey, let's increase capacity to communicate, and I think that I haven't seen that, right? So, and I think if that could happen, it would be beautiful. But so yeah, I'll say this: it just really depends on the person and the case. So, yeah. Sorry, I know that didn't answer your question.
I'm curious. So in my work, which is a bit different, right? But I am a behaviorist by training, and one of the things that we've acknowledged is that behaviorism and the application of it has been fairly destructive. Even as recently as about 10 years ago, right? I mean, there was somebody who I won't choose to name today, but who, in the experience of working with contamination OCD, decided at some point that they were going to blow their nose into a tissue and then take this tissue and toss it at somebody that was dealing with contamination, all through the lens of this is an exposure, right? And to be very clear, that is the incorrect way to do any type of behavioral work, right? It was not compassionate, right? We did not get any permission, right? We don't even know if that was in line with that individual's goals and values to begin with, right? And so while I may be a bit out of touch, I do want to acknowledge that behaviorism in general tends to work much better when it is compassionate, when it is person-centered, when it is based on the individual's values of the person that is receiving the treatment, right? I do not want to bestow my values, my beliefs onto that person in that moment. Yeah. Dr. LeFrançois, any thoughts on this idea?
I'm not entirely sure that I can answer this question well because I'm living and working in a different country with a different context around treatment. So I'm not sure that it would be helpful for me to comment on this one.
No problem. Thank you. I appreciate that. Okay. Yes, ma'am. Another question.
I just want to say, you are awesome. Like, in bringing such passion and enthusiasm, you'll make a great therapist.
Well, I do think to the point of acknowledging that, to some degree, these methods are going to be somewhat dependent on who's using them as well, right? Are they sticking to the ethical codes? Are they being open-minded? Are they allowing it to be client-centered, or are they not?
And I think, Ben, you just said it, like, are we sticking to the ethical part of that, And I appreciate, your passion and seeing the changes that you want to see in the children and adults that are coming to you. So, I think definitely if in a perfect world, if we could have everybody that's that passionate, right, and understanding ethically what that looks like, and there's not a other monetary motive there, then I think that can. Sorry, did I say that? So I think that could be that's the one of the biggest things is that passion of I want to truly see this person get better. So yeah, thank you.
I mean, statistically speaking, in all forms of education and coaching, the biggest thing you can do is believe in your kids. Actually, it's been shown study after study.
Okay, we're going to do one more question just because I've already gone
Can
over
I-
time. Oh, please.
Can
Yeah,
I
sorry.
just say something here? I
Please.
didn't hear the question, but I think I have some idea, and I just wanted to say that, research has shown that that therapy is more successful based on the quality of the therapeutic relationship. That is more important than the type of modality that you're using in therapy. I have a feeling that might be relevant. If it wasn't, I'm sorry.
Yes, no, that is extremely relevant. Yes, it is the number one factor in successful therapy. We've seen it time and time and again, and all the studies have confirmed it now for roughly 45 years. So it is definitely a part of this. We're going to do one more question just because we're already over time. Yes, sir?
I think that's completely reasonable, actually. Honestly, masking is kind of a dirty word in the community, but it's a necessary evil, too. I mean, to be fair, to navigate a lot of these situations, it's, kind of essential. So I think that is actually a really clever approach to balancing out what can be for many, a very tricky and exhausting issue.
Just quickly, let me just name the question for the people that aren't here. So we have a speech language pathologist who's essentially asking this idea of yes, but can we who also is working with folks that are dealing with some social anxiety, can we sort of acknowledge a cost-benefit analysis? And I'm paraphrasing here, but sometimes the mask may be functional. Sometimes the mask may be beneficial. It may be even easier. Okay, yeah, gotcha.
Depending on the situation, I would probably equate masking to a white lie. As Dell said, it is a necessary evil. I would think that the person who is doing the masking would decide whether or not it is more important to be honest with themselves or with what the expectation is being placed upon them. I know, like with any lie or white lie or masking, what have you, there is a chance that a response might cause problems in a workplace or in a social setting, or it may cost a friendship. The cost benefit of analysis that you are wanting to do would have been a very helpful tool for me to have growing up. But there's just a lot of different variables that go into that, and I think it's going to be very situational.
Yes, and not only situational, but it's very individualized, right? So, I'm sorry. Yes, yes, it very much would be. So I think that's one of those things where, because then after that, like making sure you have the necessities to recuperate, right? What are you gonna do to then now recuperate? Of okay, yeah, I chose to mask, and I got through it, but then what does that look like for the next 2 days, 3 days, a week, right? So then, like you said, is it worth it? And I think that's, and going back to professional hat, I think that's where someone could come in and go, okay, like, let's look at this. What does this look like, right? What does it look like if you do not mask? Would that be more beneficial for you? And sitting down to just go into detail of, like, what that may look like. And someone made a comment earlier, and I had generated a thought of, being able to, I think it was you, just how to social, or I don't even want to get back on that subject, but communicate. I'll say communicate. How to, communicating, and that growth comes in support groups. And as a clinician, what would that look like if, okay, yeah, let's have more groups where we can come in and figure out how to socialize with each other, and we are doing that. So I think ultimately, it's individualized to what is the goal, and then do you have the skills to rejuvenate that back up? So, yeah, absolutely. Great question.
Yeah, excellent question. Thank you so much. Okay.
Can I just say that
please.
I agree with those comments, and I think the problem arises when the masking is forced. But when someone is making the choice to mask to get by in a certain situation and has a plan around revitalizing themselves and having some alone time in order to get over that, I think makes a lot of sense. What doesn't make sense, or what I think could even be called violence, is when children, for example, are told they must mask, they are not allowed to stim, they must stop that they have to mask in particular ways because the goal is to say that you're cured and you're no longer autistic. And if you effectively mask and no longer show any signs of autism, you will no longer be autistic. That is where the violence comes in, not when someone is freely choosing to mask because it's going to be of benefit to them in a particular situation.
Thank you, Dr. LeFrançois. That's great. Okay, we're going to have to wrap this up. If we could get a round of applause just for everybody here today. We really appreciate y'all's willingness to be here and everything that you may have had to tolerate to do so. And yeah, I found this to be both informative and a really great conversation. Please, for everyone that's here, on page 14 of the program, there's a QR code. Please scan that so that you can fill out the survey. This helps inform us how we do these things moving forward and allows us to get some feedback on things that we might be able to do better in the future. Okay? Thank you guys so much. We really appreciate it.